So good morning to members of the viewing public, members of the media, and the officials of the stakeholder entities here with us this morning. And we have with us officials from the Ministry of Finance, the Ministry of National Security, the Ministry of Health, the Port Authority of Trinidad and Tobago, and the Airports Authority of Trinidad and Tobago. This is the first public hearing for 2020 of the Public Administration and Appropriations Committee, and it's an inquiry into the preparedness of public authorities for the potential spread of the novel coronavirus in Trinidad and Tobago. The Committee on Public Administration and Appropriations has a mandate to consider and to report to the House of Representatives on A, the budgetary expenditure of government agencies to ensure that expenditure is embarked upon in accordance with parliamentary approval. B, the budgetary expenditure of government agencies as it occurs, and to keep Parliament informed of how the budget allocation is being implemented. And C, the administration of government agencies to determine hindrances to their efficiency and to make recommendations to the government for improvement of public administration. The purpose of this meeting is to inquire into the preparedness of public authorities for the potential spread of the novel coronavirus in Trinidad and Tobago. The committee is desirous of hearing from the relevant stakeholders the plans in place to treat with the global epidemic and also the challenges being faced by the stakeholders and to identify some of the solutions to these challenges. The role of the committee is to assist the stakeholders in achieving the efficient delivery of services. This meeting is being held in public and is being broadcast live on the Parliament's Channel 11, Radio 105.5 FM, and the Parliament's YouTube channel, ParlView. Viewers and listeners can send their comments related to today's inquiry via email parl101@ttparliament.org, facebook.com/ttparliament, and Twitter @ttparliament. I will therefore ask members of the Ministry of Finance, the Ministry of National Security, the Ministry of Health, the Port Authority of Trinidad and Tobago, and the Airport Authority of Trinidad and Tobago to introduce themselves, and thereafter the committee members will introduce themselves. So we could start with the Ministry of Finance.
Yes, good morning, everyone. My name is Savitri Sipasad. I'm Acting Deputy Permanent Secretary, Ministry of Finance.
Okay, and then do we have somebody else from Ministry of Finance?
Yes, we do, yes.
Yeah. Good morning. I am Yvonne Macharan, Deputy Permanent Secretary, Ministry of Finance.
Good morning. My name is Eleanor Allen. I'm Acting Deputy Director of Budgets.
Good morning. My name is Bernard Nicholas. I'm Acting Deputy Comptroller, Customs and Excise.
Good morning. My name is Vidya Marcial. I'm Acting Deputy Comptroller, Customs and Excise Division.
Thank you. From the Ministry of National Security.
Good morning, Madam Chairman and members of the committee. Vel Lewis, Permanent Secretary in the Ministry of National Security.
Thank you very much. Ministry of Health.
Good morning, Madam Chair, members of the committee. Asif Ali, Permanent Secretary, Ministry of Health.
Hi, morning. Dr. Roshan Parasram, Chief Medical Officer, Ministry of Health.
Good morning, Madam Chair and members of the committee. Vishwanath Andy Pratap Singh, Principal Medical Officer, Environmental Health at the Ministry of Health.
Good morning all. Osafo Fraser, County Medical Officer of Health, St. George East.
And if you forgive me, I'll just go back to the Ministry of National Security. I believe you have somebody here from Immigration.
Yes, good morning. Charmaine Gandhi Andrews, Chief Immigration Officer.
I'm sorry, ma'am. Okay, and then maybe we can go on to the Port Authority of Trinidad and Tobago.
Morning to all. Trudy Gill Conlon, Acting General Manager, Port Authority of Trinidad and Tobago.
Anyone else from the Port Authority?
Good morning, Madam Chair, members of the committee. Dr. Sonia Roach, Medical Superintendent, Port Authority.
Good morning, Madam Chair, members of the committee. Guy Brown, Joy Guy Brown, Occupational Health Nurse.
Okay, and then the Airports Authority of Trinidad and Tobago.
Madam Chairman and members, good morning. Albert Griffith, Acting General Manager of the Airports Authority of Trinidad and Tobago. There are two other members of the authority present.
Morning, Madam Chair and members of the committee. Oswald Bruce, Coordinator, Airport Operations and Aviation Training.
Good morning, everyone. Kurt Menal, Acting Deputy General Manager, Operations, PAAC.
And do we have a representative from the NR? Okay. All right, so can I then invite the members of the committee to introduce themselves, starting from my extreme right?
Morning, everyone. Daniel Duki is my name, member of the committee.
Good morning, Lakram Bodo, Vice Chairman. Good morning to you. Welcome.
Good morning, all. Foster Cummings, member.
And I am Bridget Anizet George, Chairman of the committee, and today we are assisted by Ms. Kiba Jacob, the committee secretary, Mr. Jarrett, who is the graduate research assistant to the committee, and Ms. Rachel Noons, who is also the graduate research assistant to the committee. And I think we'd like to start by asking the Ministry of Health to put this in context and maybe say to the committee, what is this novel coronavirus?
Morning again, Madam Chair, members of the committee. January 30th, the World Health Organization would have declared the novel coronavirus a public health emergency of international concern. As of February 4th, WHO reported figures, there are 20,630 confirmed cases worldwide, with 426 deaths being reported globally. In an attempt to interrupt the transmission of the virus globally, there have been several measures put in place. These include closing of borders with China, restriction of flights to and from China, and thermal screening of passengers at the port of entry. Within the local context, the Ministry of Health has sought to also interrupt the transmission of the virus into the country, and has done this through two main measures: travel restrictions into Trinidad and Tobago for persons who have departed China within a 14-day period, and thermal screening of passengers at our major ports of entry, both the airports and the seaports. As of February 4th, we have screened 457 flights at approximately 34,000 persons. To date, no persons have been found to be febrile, which is with a temperature greater than 37.2 degrees Celsius. We've also embarked upon an aggressive public education campaign using both traditional and social media, as well as having the ministry officials appear on the various media platforms. The ministry also wants to take this opportunity to remind the public that they have a part to play also in terms of personal hygiene, regular washing of hands with soap and water, sneezing into napkins, and social distancing from persons with a cough or respiratory ailments. These measures are consistent with WHO guidelines, and they have already been implemented in conjunction with the relevant respective state agencies, Airports Authority, Port Authority, Immigration Division, to name a few. And the ministry also continues to collaborate with the international health agencies, PAHO, WHO, CAFA, as this develops, and we will continue to update the population in this regard. Madam Chair, in addition to these precautionary measures, and in the unlikely event that we have to treat with any cases, suspected or otherwise, the ministry is in a state of readiness in terms of isolation and quarantine facilities, personal protection equipment, pharmaceuticals, and our trained health personnel. Thank you.
Okay, so thank you. I'll take that as a sort of opening statement. But I think for the public, we need to know what is the virus and what are the symptoms of the virus. So I don't know, Permanent Secretary, if you would like to pass that on to a member of your team.
Sure. So the coronavirus is a large member of viruses, a family of viruses. What we would be familiar with in the world, we would have seen SARS in Trinidad in 2002, 2003. So that is a subtype of the broad family. There would have been Mediterranean respiratory syndrome, which is MERS, which is usually in Saudi Arabia. We have had no cases of MERS in Trinidad, although we have people frequently traveling to and from that part of the world for Hajj and other reasons. So we have been monitoring that situation for quite a number of years as well. So the novel coronavirus is a new subtype of the same family of viruses that has been identified in China, as the PS would have said, starting in December and then progressing to present. We would have had, up to the last update, about 20,000 cases of the virus. The signs and symptoms generally are not unlike any other common cold. So you tend to get, in the mild cases, you can get fevers, runny nose, cough. When it gets a little more severe, you tend to get shortness of breath associated with it. You may need hospitalization. There's been associated diarrhea and vomiting in certain cases, especially with children. But it can be a completely asymptomatic at times, no symptoms presenting. Basically, the death rate has been calculated thus far around 3%. When we looked at SARS, it would have been closer to 10%. To put it into context, with something like Ebola, we're looking at 30 to 50% mortality. So just in the global context of it. Something like influenza will be less than 1% mortality death rate. So just for a start, yeah?
Okay, so as you said, it belongs to a family of viruses. It could look like any flu. So what makes this so different?
Well, I think what is happening globally in terms of the nature of spread and the speed at which it's spreading in China is the main issue. So on the 25th of January, just a few days ago, about just over a week, there would have been a confirmed 1,297 cases. To date, there's 20,000. Between the 25th and present, there are over 20,000 confirmed cases. So we have over 1,000% increase in just a few days. So it seemed to be galloping along in terms of the epidemic. And not only that, the number of countries that would have had imported cases, and now some of them having cases being spread from person to person in those countries, have increased rapidly to over 20 countries in a very short time. So it's the nature of spread that is concerning at this point. Of course, the death rate being a little bit more at this point than influenza, and that is calculated based on confirmed cases. So we expect retrospectively, when you do a study of the actual cases, suspected cases taken into consideration, the death rate will actually be much less than that, or similar to influenza. But I think the main thing is the way it has spread in China and to other parts of the world has led WHO to declare a public health emergency of international concern. And because of the small island developing states and other smaller territories not having the capacity generally, as would China and US and larger territories, to deal with an epidemic of that magnitude, WHO and the Director General has indicated that, bearing in mind the smaller countries and their capacity, he had declared an emergency of international concern based on that.
Okay, so let me ask something. Again, for the public, the symptoms, since they're like flu-like symptoms, how would I know as an individual that it's not the flu that I should take some bush for, or some homemade concoction, and that I need to go to the doctor?
So for now, for the citizens of Trinidad and Tobago, we have no suspected or confirmed cases in the country. There's no spread in this country because we have no cases. The only way you can get the virus at this point is if you have contact with a country that has ongoing transmission. The main country that has that is China. So first of all, in terms of the case definition, you would have to be coming from China. If you come from China within 14 days and you develop any of these normal signs of symptoms of a cough and cold or whatever it may be, you need to report to a healthcare facility immediately. You cannot determine on your own that it's coronavirus or something else. Certain tests need to be done by the physician to actually ascertain whether it is coronavirus or something else. So the first thing is, once you have signs and symptoms, you take the necessary steps to get to your healthcare facility as fast as possible, because you can't just assume that it's a normal virus that you have. We have to test it to see.
Okay, so once I have symptoms having come in from China,
sure.
What about if I've had contact with somebody who's been in China?
Of course. So, I mean, any sort of contact. So even if you have contact with maybe a case, you know of having contact with a case in the US or other territory as well.
Yes.
That will have to be the starting point. If you have no contact of any sort, and you can assume generally that we don't have the coronavirus.
Okay, thank you. Yeah. All right, so I'll invite any member of the committee who would like to ask a question. Dr. Bodo.
Thank you very much, Chair, and again, welcome to members of the committee. I just wanted to ask in terms of the reporting, through you, Permanent Secretary, perhaps I can, as the CMO, in terms of the reporting and the figures you're getting, are you getting it daily from the WHO?
It's daily reporting from WHO. They send situation updates every day. So they have the suspected cases, the number of confirmed cases, sorry, the number of deaths, the number of countries that would have been affected on a daily basis.
Right. Would you say that the WHO is satisfied that the information coming from China is fairly accurate? Is there any concern at all about that? I'm just asking.
I think the concern is actually any surveillance system wouldn't give you 100% of cases. The concern from WHO, I think, I can't speak for WHO, but the concern looking on at the figures is that the suspected cases are not being reported, meaning persons that meet the case definition and don't have a confirmatory test. So we don't know how many suspected cases there are.
And of course, you'd understand the reason I'm asking, because
Yeah.
we want to try and define the magnitude of the problem. In terms of the deaths and the resources that are available in China, has there been any initial analysis of what is causing these deaths? In other words, are patients dying because they are not seeking medical attention, or are they dying in hospitals in spite of the best available treatment? I know it's a difficult question, but I don't know if you can.
I know the simple research points to persons of high-risk groups in the first instance, which with any respiratory virus would affect persons of certain groups, over 65, children under 5, those people that are immunocompromised for any reason. But I don't think enough research has been done to define it in that way, to say, why are these people dying? At least we are not privy to that information as yet.
And of course, the reason I'll be asking that is just in case, in the unlikely event, as you stated, Permanent Secretary, that we do have a case, we want to have the assurance that our facilities are going to be able to handle those cases. So you understand why I'm asking that?
Yeah.
But there's no research to suggest whether these patients are, or no
I
information
don't
rather.
think we are privy as the world as yet to a full analysis of exactly what is happening epidemiologically and clinically in those cases.
Right.
But having said that, again, the high-risk groups are usually at risk for respiratory illnesses. And the virus, there's no specific treatment at this time, given that the rate of death is pretty low still, comparatively. We think that our system, of course, dealing with influenza as we are now, influenza is a very severe illness of the same type. So our system is meant to be able to cope with those kinds of cases. I think we will be able to cope in the event that we do have a suspected or confirmed case.
How confident are you that there is no case of coronavirus in Trinidad and Tobago at this time?
I think I can say fairly confidently that we have no case.
All right. Now, let me just ask you about the thermoscanning, which is the temperature. You mentioned that there's none of the persons screened would have exhibited a temperature of more than 37 degrees. At what point in the evolution of the virus would that be a reliable indicator?
Well, the incubation period being 14 days. So anywhere during the incubation period, you can develop symptoms. So in terms of a reliable screen, if you have a passenger coming through, within the 14 days not developing symptoms, of course, it won't pick you up at any stage. And hence the reason we went towards restriction, because there would be people coming in from China in the first instance, well people in terms of having no symptoms. But according to the epidemiology and what they are saying to us is there's a possibility that the virus, unlike SARS, unlike MERS, can be spread prior to the onset of symptoms, and even unlike Ebola, which means you can't detect it. And then, of course, spread during persons who actually have no symptoms. The asymptomatic persons spreading the virus has come to bear as well. We took the decision to go to Cabinet to actually restrict travel based on those two factors, along with the fact that we have no vaccine and we have no specific treatment at this time.
The newspaper's report suggests that the passenger was turned back from PAAC Airport yesterday. Would you want to explain on what basis that was done?
So based on the restriction, it says that a non-national who comes to Trinidad within the incubation period should be denied entry, and I think that was done. The chief immigration officer may want to come in as well. She was in contact with her officers. It is an immigration response once we deny entry. So the health part of it is that the port health officers has to have some suspicion, which is part of the legislation. Our officers would have seen the person just coming from China at this point is suspicion enough, and then the immigration laws would kick in. So I don't know if the Chief Immigration wants to speak to that particular case.
Yeah, sure.
Hi, yes. So, of course, with the travel ban being that the passenger should not come into Trinidad and Tobago within 14 days of leaving China, once the passenger was identified, referred to Port Health, they were refused entry because of the potential risk, as outlined by Dr. Parasram, and they were returned to their port of embarkation, which is a standard procedure when we are refusing anybody entry into Trinidad and Tobago. They go back to their port of embarkation, and then the next country would determine what they want to do at that point in time.
Sure. Those members of your staff, Chief Immigration Officer, who would have interacted with this particular passenger, would there be any particular precautions in terms of observation, information, and any reporting requirement for those who would have been in contact with that passenger?
Well, the officers take the necessary precautions already, and at this time of the year when we're treating with an inflow of persons, they do take necessary precautions against even the flu. So yes, they would monitor themselves, and if they did not have direct contact with the individual, of course they were utilizing their gloves and whatnot to examine the passports, etc. The passenger was put into isolation at Port Health and dealt with accordingly. But certainly any officer, not just an officer, any person who might have come into contact, and I'm speaking about airline agents, etc., should monitor themselves to see if they are coming down with any fever, and if they are, then they take the necessary precautions, or they report, like Dr. Parasram has said, to a doctor for medical examination.
The other passengers on this flight, would they be CMO, would they be required to report or given any special advice?
At this point, based on the Port Health...
I'm presuming they would all have been screened.
Of course, but based on Port Health actual interaction with the passenger, I don't think she would have been, although the restriction is in place, which we want to enforce, she would have been a high-risk case. And Dr. Fraser could actually speak to a bit of the history that was done of this particular case and why he would consider her very low risk of having anything.
That would be useful. Thank you.
Okay, good morning. This particular individual would have left China around the 29th of January, and she would have traveled to Guyana for a short period of time, and then she came to Trinidad. At the time of entry, she was completely asymptomatic. She did not have a fever, and she exhibited no signs at all of a respiratory illness. In fact, she was a little surprised that she was being asked any questions because she was so well. So she did not have any contact, because we asked, she didn't have any contact with anyone who was ill during the period of time that she was in China and when she left. So she would be considered a very low-risk individual for even having the disease, much as to spread it.
Sure. Would there be any mechanism, let's say, would there be anything in place for us to find out in Trinidad if subsequently she develops the coronavirus while she's in Guyana? I'm presuming that she was sent back to her
Guyana,
home country.
yes. So under the international health regulations, Guyana will report it to the PAHO WHO on the IHR focal point, which is usually the CM of the country. They will report it onwards to us as well if there's any issue. We have received no such report at this point.
Yeah, sure.
I just wanted to ask something. What about the passengers? So you say the passengers on that flight are also considered low risk. Okay, so that passengers on that flight, other than going through the normal screening, would not have been alerted.
Because of her personally low risk upon history, and Dr. Fraser wouldn't have indicated that she would have gone from, I believe, Hong Kong to New York, from New York to Guyana, then to Trinidad after spending some time in Guyana. And U.S. has stringent measures in place in terms of history as well before they actually allow you in. So there was a number of assurances along the way. There's exit screening in China as well that is ongoing. So if you are coming from the province that is affected, they do actually allow you to leave at this point. So there's assurances as we go through the different areas, and we think she was very low risk, but we still want to stick with our travel restriction.
Right. So you're saying the number of screening levels that this passenger would have gone through, in addition to the fact that she was asymptomatic, would have all been taken into account to say that she was low risk.
Yes.
Okay, but there's a risk anyhow.
Very
Small, but there
very,
is.
very slim, yes.
Okay. So that in terms of having regard to that, you feel that even the risk to other travelers on the plane would be as low or lower?
Yes, lower.
Okay. Member Oliver.
Thank you very much. Well, just for clarity, certainly for the population listening, from the time the person comes into contact with the virus, there's a 2-week period before symptoms will develop. What do we know exactly at what point transmission is possible? I mean, although you are asymptomatic, I mean, can you start transmitting within 1 day of coming into contact?
Right, so the usual rule of thumb for these kinds of viruses is that when you start to develop symptoms, you are usually transmissible just before. For this, and why we are concerned is that they are saying no, for this one, once you actually have the virus, you can transmit. Of course, research has to be done to see if that is so or not, and we are basing it on that premise. So from the day of actual exposure, we expect that you may be able to transmit, and that's the concern.
Okay, so in terms of persons who may have entered the country before the 14-day ban was imposed, now this may be better directed to immigration, but are you looking back at your records then to see if prior to that 14-day period, if persons had come into the country who would have been in China, and are you following up with them, actively going and finding these persons in the population to ensure that they remain asymptomatic?
We started the process of identifying persons who may have come from China. That's a little bit difficult with the system that we have because our advanced passenger information really only tracks the person's last port of entry or their last port of embarkation. The Joint Regional Communications Center is now screening everybody to see if they have information about their travel history prior to that. So there were only maybe one person coming in from China prior to that in Tobago, which was dealt with, and that person, of course, was similar to this individual yesterday. They were not found to be symptomatic of the disease. But we are still looking and tracking all of those persons who might have come in from China. So we've narrowed that down to a few, and that information would be transmitted to the Ministry of Health for further evaluation. But like I said, it was only a small number, and from what we saw, the persons had not been in any of the center during the last 14 days. So.
In addition to those individuals, are you also widening your search, your review, and looking at the other persons who would have been on the flights with them, just checking with them to make sure that they are also asymptomatic?
Like I said, that information would be passed on to the Ministry of Health. We have been looking at it, like I said, and certainly it's not as easy as we would like to think. In terms of trying to identify the persons and where they originated, especially if they're coming from China, because there are different ports that they would transit through. So it's not that easy. So we're just narrowing down persons who we might have granted a visa to come into Trinidad and Tobago if that person has entered the country. And that is what is ongoing now for us to try to identify those and pass that information on to the Ministry of Health.
Okay, member comments?
Thank you, Chairman. This is for Dr. Parashram. In terms of the countries that you mentioned, I think you said 20 countries where there are possible cases, am I correct? Outside of China?
Outside of China, 22, the latest WHO bulletin.
Of those countries, those 22 countries, any countries in the region, the Western Hemisphere? Or?
Yeah, US, as we said before, and Canada had cases from pretty early on in January. But no other countries in the Caribbean region have had cases. There was one suspected case in Jamaica about a week ago, I would say, which turned out to be negative. But other than that, no. There were a couple of persons aboard a cruise ship, I think, in Grenada a couple of days ago. Grenada has now had a restriction very similar to Trinidad as of the last few days, but nobody in the region, as far as we know, up to our bulletin yesterday.
In terms of nationals of Trinidad and Tobago returning from China, what is the protocol in place for that?
Right. So the protocol in place is to allow them entry, do the risk assessment through Port Health again. And a lot of the cases we are being notified prior through Foreign Affairs if they are to return. So we have things in place beforehand. And we are doing once they're low risk, they have no symptoms, we're doing home quarantine for the 14 days or for the remainder of the period. If they come in and they only have 4 days left, we do home quarantine where a CMOH office will be assigned to them. They will go in every day if need be to take temperatures. They will do phone conversations with them, letting them know, finding out if they're well, if they develop any fevers or any signs. And once that happens, then we take them into isolation right away. But the international norm is home quarantine.
Now, you did mention that there is no vaccine for this virus.
Yeah.
And so I'm asking, in the event, in the unlikely event that we do have a suspected case, what happens in that?
Yeah, so once we pick up a suspected case, I think really and truly the key focus is to prevent spread to any other member of the population, in which case the person is isolated right away or quarantined as need be and remains until we deem that the person is no longer transmissible, and all the contacts around that person, same thing will hold.
Okay, this is the Dr. Parasam, just as a follow-up. I'm hearing the term isolation,
right,
and I'm hearing the term quarantine.
Well,
as a layman, it means the same thing. I don't get the impression from the way it's being used that it's the same thing. So maybe you could explain to us, what the difference is.
I mean, in just for general understanding, quarantine seems to be a higher end sort of isolation, a scale up, if you want to say. So isolation wouldn't have all the bells and whistles from a public health perspective that quarantine would have, in terms of the systems that you have around, structural systems, engineering systems that you would have in place. So the actual physical infrastructure of the room will be different in that particular instance. So quarantine implies a higher scale of isolation in terms of the lockdown. So you'll tend to hear words like negative air pressure and those kinds of things to actually contain pathogens. Isolation is a little lower scale.
So in terms of a case that we were just discussing, you said the person was placed on home quarantine.
Yeah.
What does that mean?
Well, maybe I should have said home isolation, right? But quarantine in the sense, as the definition would imply, means that you have no really contact with anyone else, generally speaking. And we will only do home quarantine if your risk is extremely low. Once we have an inkling that they would have come into contact with the virus, it will be hospital isolation rather than.
Okay, so home quarantine is self-regulated.
Well, it's not you're not left on your own. You're monitored by the CMOH and the staff of the CMOH on a 24-hour basis.
So they go there daily, and
they have phone conversations because we want to limit exposure to persons as well. So they have phone conversations. If they have to go, they wear the PPE and they do temperatures if need be. But the main and the basic thing that we have been doing for MERS as well is doing phone call-ins every day to determine if they have any signs and symptoms. And of course, if they do, then we go in and take them out.
So if someone is home quarantine, it means that there's nobody else in the home also.
Well, and that's not always the case. And that's why we have to determine the risk, and we are just going on the premise of the 14 days incubation period. So if it is that somebody develops symptoms, everyone else is presumed exposed, and that's why I said to Member Cummings that everyone else that is exposed will have to be isolated thereafter. So there's that understanding between the patient and the physicians that basically home quarantine means that if we do develop something, that everybody has to be isolated thereafter.
So it is self-regulated with surveillance.
Yeah, to the most part.
All right. So that.
But having said that, the there was a notice, the proclamation by the president, which added the novel coronavirus to the public health ordinance, the quarantine list, on Friday last, about 2 p.m., I think it was gazetted, which gives us the legal teeth, for want of a better word, to actually do quarantine under the act, if need be. So the novel coronavirus was added to that list to allow us to, under the law, actually quarantine as need be beyond self-regulation.
So at the airport, what do we have? Isolation facilities
Well, I would
or
say isolation.
Isolation.
Yeah.
So maybe to the immigration officer, or I don't know, it might be health. The case we first discussed about the person being turned back, would that person been placed in isolation while they waited to board a
Yeah,
flight to go back?
And they would have, yeah. They were taken straight to the port health unit, which has 2 isolation beds, and they stayed on until they were meant to depart from there.
All right, and do we have quarantine facilities here?
At the?
Do we have quarantine?
In Trinidad?
Yes?
Yes, we do. We have 4 beds at the Cora Hospital, which is considered our quarantine for this particular event.
Okay, so that's all we have, 4 beds?
Well, 4, yeah. We don't think we would expect anything more than that.
Okay, and therefore may I ask the Ministry of Finance, in terms of, is there any sort of emergency funding, or if there is, what is the protocol in the event that something else occurred?
At present, ministries and departments would have, funding from the appropriation if they need to purchase any supplies. So the question would be them requesting from the Ministry of Finance any funding that is required, which will be provided. And if it comes to a point where additional funding is required, or we come to a point where it has turned out to be, a bigger disaster than anticipated, there is the contingencies fund that is available. I guess the cabinet and the ministers would make a determination on whether that is necessary, and if that is the case, then the Ministry of Finance will put that in effect to have monies withdrawn from the fund.
So I just wanted to ask, Madam Deputy PS, I understood you saying that there's an allocation and appropriation. Very often ministries come before us and there are problems with releases. And therefore, while they may have an appropriation, and they may not, it's early, relatively early in the fiscal year, so we don't expect that they've, dug deeply into that. What we're really concerned about, in the event that something happens, the relationship and the protocols in terms of releases.
Well, we do have a person from the budget division, but I'll just share with you. The understanding from the Ministry of Finance is that once the request is made by the ministry with respect to these matters, it will be dealt with immediately. And as you rightly said, we are early in the year, so there is appropriation. There's the opportunity for immediate releases and ensuring that credits are made available.
Thank you. Member Duki?
Thank you, Madam Chair. And maybe I should direct this to the Permanent Secretary in the Ministry of Health and could be redirected if necessary. With the expected increase in arrivals, given the season that we're in, and it may increase continuously as we get closer to the date, are we really satisfied that we are prepared to deal with this situation we are discussing? Because the assumption I am making is that an increase in arrival could also impact the risk that is associated with this particular virus. So are we satisfied that we are well prepared as we get closer to the days of Carnival, where we will expect an increase in arrivals?
So if we had no restriction in travel from China, I would be very concerned. But because we have a restriction in travel from China, we expect that people coming from Trinidad and people coming for this season generally will be people from North America, from Canada, from UK, North America. US has actually had a travel restriction in place recently as well. So I don't think there would be, of course there would be a high influx of passengers, but I don't think from the risky areas that will be of concern for this particular illness.
And hence, you would see, I'm asking, you don't see a relationship between the increase in volume that we expect and the amount of isolation and quarantine facilities that are necessary.
I don't think so, not because we're not expecting a case because we have restrictions in place.
Thank you.
Member comments?
Thank you, Chair. This question is for the Port Authority. I know we do a lot of trade with China, and hearing a lot about the restrictions in terms of the air travel. What is in place at the port, and are there restrictions as well in terms of ships that will be sailing from China, and how those crew members interact with members of the public here coming abroad for supplies and so forth? What is in place there?
Thank you. The legislation that has been enacted would apply in terms of travel ban from China. The standard operating procedures is that the crew and the crew information, vessel information in terms of last ports of calls is submitted, and immigration views that information. So the determination of crew and vessels entering Trinidad and Tobago from China, and I would say vessels come from Asia, they would take generally more than 14 days, and again, they stop in various ports, so they don't come directly from Asia, not just China. So the methods that are in place in other ports would also apply, as would travel from other airports. But the immigration is the body that takes care of reviewing and screening of passenger and crew information to determine who can enter and who cannot enter into the port.
Then my question should have been posed to immigration. So can I get a comment from the immigration on this?
Thank you. As the person from the Port Authority would have indicated, vessels coming in send their information well in advance. Under the ISPS code, they are required to transmit information at least 96 hours ahead of their arrival into Trinidad and Tobago. It's easier to quarantine a ship if there's some illness on board than perhaps an aircraft. And at least we would have the information ahead of time. The captain is required to report if there's any person exhibiting any kind of illness on board the vessel. And once they indicate that to us, we immediately contact Port Health, and they would visit the ship and examine any person on board before granting pratique. Because nobody could go on board a ship unless free pratique is given, or pratique meaning that the ship is free and clear of all diseases and whatnot, and it is safe for persons to go on board a vessel in terms of a ship. So those protocols are there in place. We get the information, we can scrub the list to see if any passenger, or if any crew member, because it's mostly crew members we're dealing with, are from one of those affected, well, from China. But the ship really takes a long time to get here, and somewhere along that journey, it might have been identified that that person was exhibiting symptoms of some illness, and it would have been dealt with. Or if it was on its way to Trinidad, they would have transmitted that information to us right away because of the time it takes for a ship to get into port. So the protocols will apply. The vessel would be quarantined. The Ministry of Health, the Port Health Division would examine the crew on board and make the necessary determinations at that point in time.
Do you have anyone from Port Health here? Yes?
I mean, just to add to what you said, in terms of the ships, I think the Cruise Line Association, which will deal with the cruise lines, and I think people have a concern with a lot of cruise ships coming in and a lot of people coming into the country. The association, as of the 30th of January, which covers most cruise ships, if not all, that comes to our shores and the Caribbean, issued a similar travel restriction indicating that no passenger or crew will be allowed to board that emanated from mainland China. And that is as of the 30th of January and continuing. So the cruise ships, we don't expect anyone on board from mainland China being allowed in a cruise ship. So that deals with the cruise ships as separately. What the Chief Immigration Officer was speaking to are the other ships, the cargo ships and elsewhere, and our immigration restriction remains in place for anyone leaving mainland China 14 days or less, with or without symptoms.
Okay, so Member Dion Ryan.
Thank you, Madam Chair. Good morning, everybody. To the Chief Medical Officer, I have a question about in terms of our laboratories equipped with the relevant testing materials to conduct testing to confirm
Right, sure.
whether a patient is infected with the virus?
Right, so the lab that normally confirms any type of illness, any type of virus like this is usually the Caribbean Public Health Agency. So they have indicated to us that in the interim, if we get a case today, samples would be taken by the Trinidad Public Health Lab and sent to CDC for confirmation, Center for Disease Control. Hopefully by very early next week, the CAFA, which is based in Trinidad and is a regional lab, will have the capacity to do PCR, polymerase chain reaction test, which will actually be able to test at a high level of specificity whether you have it or not. Hopefully by Monday or Tuesday of next week, they should have that capacity, which means that within 48 hours of taking a sample, we should be able to get a result in Trinidad.
Okay, thank you for your answer. Now, just for the listening public, the testing that is done to confirm whether someone is infected with the virus is not a blood test. It's a swab, which is because it is an upper respiratory infection, right?
So it can actually be, and what is recommended is either one or a combination of tests. So you can do what is called nasopharyngeal swab, which is the upper respiratory that you alluded to. You can do actually urine test, which actually picks up the virus for a longer period of time. So you could do a urine test, or you can do serum samples. Serum basically is blood samples. So actually a combination of nasopharyngeal and serum is the best way to actually determine whether you decreases the level of false negatives, because you're picking up actually what is in the blood at the present time as well as what is in your nasopharynx. So what is recommended by CAFA is doing both at the same time as best practice, but of course one or the other can pick up a positive.
And both of them needs to be sent to CDC for testing?
Generally speaking, all samples that we send to CAFA at this point will go onward to CDC if there's a high degree of suspicion.
And in terms of the transportation of these samples that would have been taken,
Right.
are they susceptible for?
Not any different from the samples that we send for influenza. But at this point, it must be said that CAFA can actually test for influenza virus. So we can say whether it is an influenza at this point, right in Trinidad, within the same time frame, 24 to 48 hours. We will be able to say whether it is any of 14 other pathogens of the respiratory family. They may be able to identify broadly that it belongs to the coronavirus family, but not necessarily. We can't test for the novel until next week, but we will be able to say broadly. So it gives us at least an idea of what we're dealing with early on.
Okay, thank you. I have one question to the Chief Immigration Officer. Now, I understand you have the APIS system, which is what you're using to track persons who would have been to China or would have had any sort of interaction or travel from the country. What about if persons have two passports and they use one passport to travel from one port of destination to another, and then they use another passport to come from Canada or the US to Trinidad and Tobago? Are you all equipped to determine whether persons have two passports?
That's a very loaded question, by the way, that I could probably spend the whole day answering. The thing is, through JRCC, they are able to use the PNR information, personal name record information, to determine whether a passenger, regardless of the passport that they would have used, has originated in China. So JRCC is using their protocols, screening all of the API information. If someone, for some reason, let's say, escapes that, when they arrive in Trinidad, they must declare on the declaration form the countries that they have visited over the last 6 weeks. And that's a requirement. Right now, the officers are ensuring that the passenger fills that out. They're questioning them. And they're examining, of course, passports to look at their travel history. So that's the other way that we would know if someone was in China recently, because the stamps would be there to show. But those are the things that we have to rely on: the advanced passenger information and the PNR record. Our API legislation does not cater for PNR, and that's one of our challenges that we have to overcome. However, because of the potential risk to the region and the fact that JRCC receives the advanced passenger information for all of the CARICOM countries, and they scrub that list against different watch lists and find out where the passenger originated, they are able to identify that as a hit, that individual, if they originated from China, and transmit that information to the destination state. So once they get that hit, they will alert us, and then we will alert Port Health so that they can meet that aircraft at the gate. So those are the things that we have to work with right now.
Member Boodoo.
Thank you, Madam Chair. Just a few follow-up questions. Now, we've been speaking about transmission person to person and so on. Just so the public information, CMO, in terms of FedEx packages, mail, and so on that will be coming, in terms of the viability of this virus, its ability to survive, can you give any indication as to whether there's any risk with regards to that?
I think generally the risks should be low, I mean, because of the distance in terms of travel. But of course, any viral pathogen can present itself on fomites on fixed surfaces for a certain length of time. Again, it's a brand new virus, and the research would not tell us exactly how long that is at this point.
So therefore,
but of course, normal precautions you should take. Of course, hand washing when handling, using the sanitizer if you don't have the hand wash frequently as possible. Those sorts of things will help.
So in terms of those coming through various agencies and so on, would these agencies or have these agencies been so advised?
In terms of the samples that would be sent, or in particular?
No, in terms of like mail and FedEx packages.
Yeah, so our mass media campaign and our social media, which is actually supposed to be doing text messages, hopefully sometime soon, and we have it on our Facebook page. We'll try to get to those agencies. We have had targeted training for some of the lead frontline agencies already to ensure that their staff know how to handle these things. Customs and immigration would be the key frontline people in the first instance, but all the agencies that are involved, we plan over the next week or two to have sit-down training sessions with them so that they could actually have their questions posed and answered.
So in terms of the, now we have several nationals abroad in China. Has the ministry been in communication with them? Is there?
Yeah, so the Ministry of Foreign Affairs would have been in communication through their consulate. As a whole, I believe there was a statement in the Express maybe last week that said there was roughly about 120 nationals in China at the time. We have not received any indication from Foreign Affairs, although we reached out to them to say that there would have been a mass return of people, that people wanted to return. But we would have been informed through different organizations of people coming in individually from China, and we would have dealt with it similarly as we discussed in terms of home quarantine as the need be for those individual cases. But we would not have gotten, say, bringing in all persons back. There was no indication from Foreign Affairs as yet that people wanted to come back home.
If these persons were to request returning home as nationals, of course they will be allowed.
Yeah.
But has a policy position been taken as to whether they will be dealt with on an individual basis, or would they all be subject to quarantine in view of the fact that they would be considered high risk?
Right. If they are coming in individually, it's easier to do the home quarantine. If they're coming in as a group, as US would have done, they brought in a group of people and actually had them at the Air Force Base, we would have to consider having a site designated and bringing, if they're coming in terms of 100 people at the same time, and having them that group of people be quarantined as a group. would be the wiser choice.
So that has been considered?
It has been considered, but we have received no request from Foreign Affairs to this date.
Sure. In terms of, and this is just speculation, but you would be far more informed than I am at this point. In terms of how far away we would be from a vaccine, any indication from the scientific?
The only indication we have is that they are fast at work of developing a vaccine. Generally, any vaccine takes a number of years to go from design to actually being able to be used on an individual. So I think we would be years away, generally speaking.
Yeah, I just wanted to go back to the travel ban, and I know that the government was very proactive in terms of taking that decision. But I just want to refer to Article 43 of the International Health Regulations, which I'm sure you're familiar with. And in terms of the obligation to report the travel ban to the WHO, and the fact that the WHO itself has cautioned against actions that promote stigma, discrimination, and so on, and they themselves did not support a travel ban. How were you able to justify this?
Right.
And so I see you smiling. How were we able to justify this? And secondly, has the WHO asked for any sort of explanation or asked you to reconsider?
As the IHR national focal point, the obligation under 43 is to report within 48 hours of any travel restriction, which was done. Actually, I did it within a few hours of doing the travel restriction on the same afternoon, Friday afternoon, I believe. They thereafter asked for justification. My main justification, of course, which I discussed before, is really the rampant spread within China from the 25th to present, that present date at the time. The spread to other countries. Having considered the fact that we have a lot of Chinese persons residing in Trinidad and going to and from on a frequent basis, almost daily, for the construction industry, as well as other areas, as well as the four justifications I used was, one, the transmission during the incubation period as a potential, having asymptomatic persons being able to transmit, the fact that we have no specific vaccine, and the fact that we have no vaccine and we have no specific treatment, is what I quoted to WHO, and to PAHO, and they sent it on to WHO on Saturday, I believe.
And have they been satisfied with that?
They have been satisfied, and beyond that, I think after, we would have been the third country in the world to do restriction, would have been Hong Kong, Russia, and then Trinidad. And beyond us, WHO announced yesterday during a COSOD meeting that 23 other countries in the region would have done similar.
I want to commend you, CMO, for standing your ground against a big international organization and making what I think is the right decision, and of course, PS as well. I just want to ask one more question, Madam Chair, with your permission. And this is going back to the resources, and perhaps, Madam Deputy PS, I could direct this question to you. And we spoke about resources, and there's something that is troubling me and has troubled me since the budget allocation discussion for the Ministry of Health in this financial year. And I had asked a question about the allocation for drugs and other related materials and supplies, which would pertain to some of the things that would be required, especially with the hospitals and the RHAs and so on. And I'm not sure if you would be aware, but there was an allocation, a decrease in that allocation of $430,962,200 in the 2020 budget allocation under materials and supplies, drugs and other related materials and supplies. The Minister of Health did not answer this question, in fact. Minister of Finance attempted to answer the question. Can you provide any clarification as to whether that shortfall has since been dealt with? You look a little bit like you're not sure what I'm talking about.
Yes, it's because it's not something that I'm familiar with, so I would want to defer to the person from the budget division. They may have more information than I do.
Sure.
Thank you. I can't speak specifically to the reason for the decrease. Usually it is based on what is the total allocation for the year based on the deficit and funding. However, if the funds turn out to be insufficient, we can do variants or transfers from other sub-items, and we can also do supplementation during the mid-year review.
I'm sure that can be done, but you can't indicate at this point in time whether that issue has been dealt with?
I'll have to check. I can't see.
Okay, can you undertake then, with your permission, Chair, to provide a response to that in writing?
Sure.
Thank you very much.
Member Duki.
Thank you, Madam Chair. To the Permanent Secretary, Ministry of Health, again. Some information out there may not be accurate. Some may be very relevant, very accurate, and citizens may not know what is accurate and what may not be, and what is relevant to the situation. What is the ministry doing to ensure that accurate and relevant and timely information is being fed to the population?
Thank you. Through you, Chair. So as I mentioned earlier, and Samuel alluded to it, we have a public education campaign. We're doing that both on our traditional media, print, radio, television, on our social media platforms, Twitter, Facebook. So there's information available on our Facebook page. As recently as yesterday morning, Dr. Partap Singh appeared on television. So we have our technical officers appearing on television, radio, talk show, putting the information out there. It's also available on our website. And we are working with Ministry of Communication to also ensure that message gets out there. So we have been stepping up the communication campaign, understanding that the fake news has been an issue. And I do appreciate what you're speaking about. We have seen some of those videos and articles circulating on social media, on the WhatsApp, and we've been seeking to address those by putting out the information proactively. All right? And there's still work to be done. All right, but that is something that we are working on.
What type of feedback you're getting in terms of the adequacy of your communication system in this regard?
Okay, so in terms of feedback, the information is relevant, so we have no issues with the information. In terms of the feedback, feedback is that we need to do a bit more of it. It has to ramp up, and that's what I said, we have to really ramp it up. So together with Ministry of Communication, we're working on that. We've also reached out to other entities, some of the other media providers, to also work with us to really get the message out there.
Mr. P.S., have you all considered engaging artists and FET promoters in your communication drive in this season?
That's an excellent idea, Madam Chair. So we've reached out to them in terms of providing education to them, but to use them to give the message out, that's also an excellent idea. We will take that on board.
Member Oliver, thank you.
Thank you very much. Well, I have a number of follow-up questions based on the discussion before, but as we on that last point, that is a good point in terms of using the artist code. So there is a extempo competition this weekend I'm attending. I will suggest that they do a verse on information about novel coronavirus, and that might help in your campaign. But I want to ask a couple questions. So now we spoke earlier about the virus's ability to survive on surfaces. How long would it be viable on a surface? So this is important for like packages that are being shipped into the country.
As Dr. Buddha would have asked a similar question. Because it's a new virus, we can't say for sure at this point. But bearing in mind it is a respiratory illness, we expect that, it can vary. It can vary. It can be maybe from a few hours to a few days, I would say, generally speaking. Depends on what kinds of conditions, environmental conditions is it exposed to, and those sorts of things, and the type of packaging.
Okay, so if I'm ordering a shipment from Amazon, I don't know what ports it would have come through.
Mm-hmm.
What do I do to make sure that my package doesn't have the virus
The precaution is to wear gloves and use a sanitizing cloth. Wipe it clean before you even open it. That's the main precaution.
Wipe it with rub and alcohol, methylated
Any
spirits,
sort of any sort of sanitizing cloth or agent.
Okay,
But
so
wear
that-
gloves while you do so, or wash your hands thoroughly after.
Well, I'd want to make sure I clean it off the surface,
Yeah.
number one.
Yeah.
Okay, thank you for that. Now, on the issue of the quarantine beds, you indicated that we have 4 quarantine beds at Cora Hospital.
Sure.
Now, if a situation arises that we need additional beds,
Right.
how quickly can that be done? How much can we get? What's the feasibility
There
of
is
increasing that
another
number?
space that may be allocated very close to the quarantine site, which is an empty space. It is a building on the same site with Cora. So we can convert that within a few hours to days if need be, using trolleys, as can be done in any disaster. ODPM has a series of tents that we can use similarly, which we have used in Port of Spain General before. So it can be converted and can be scaled up. Of course, not to the level of that area, but if there are ill people, they can be placed. And the general rule of thumb is at least 2 to 3 meters apart in between the persons. So we can do that using the empty space that we have.
So we are confident that should the need arise, we can mobilize within less than 24 hours to increase the numbers.
Yeah.
You have everything prepared.
Yeah.
That would facilitate that. All right, let me go back to immigration. I'm trying to get a sense of how much electronic data capture is done. So when a traveler fills in their form that indicates if they're honest about the places that they have been on their before arriving at PAAC. Number one, is that information captured electronically? Does the immigration officer, when they're going through your passport, do they look at your passport stamps on a regular basis, and is that information then captured? So are we really keeping a track of persons' travel history on a normal basis?
You're asking me to let out immigration secrets. But yes, we do track everybody's travel history, where they're coming from, where they're going to. Officers do examine passports, or I should say should be examining passports, to see where the passenger is coming from. Like I said, our advanced passenger information and the legislation only caters for embarkation from the last port from which they embarked. And that's why it is important for the passenger to declare on the declaration form where they would have been in the last 6 weeks. What persons need to understand, that's a declaration form under the legislation. And if you make a false declaration, you are subject to being prosecuted under the Immigration Act for making a false declaration. And it's $50,000 and 3 years imprisonment. Just putting that's the offense, right? And the penalty for the offense. So we can track it as far as possible with JRCC. Yes, they can do so much in terms of tracking where the person would have originated from. At this point in time, there are heightened measures. We would have sent out staff instructions to the officers advising that they need to do more in-depth screening of the individuals, especially if they're suspected of coming from China. So it's really based on what they see in the passport, which is a normal thing that we would do. If they're originating from China, did they have a visa for entry? And when they would have acquired that, when they would have left China. So those are the things that we would take into consideration and refer to Port Health for further screening. And I'd like to say it's not just Chinese nationals, because that's stereotyping. There are a number of other nationalities who live and reside and work in China and who may also be affected. So we have to make sure that we're not stereotyping Chinese nationals, but rather any passenger emanating from China. And that's what we're doing now.
Well, further question. In review of our maritime trade, both passengers and cargo, are we looking at, well, there are a number of fishing trawlers, you have CARICOM wharves, you have a bunkering industry. So is the net really expanding out to these type of persons? I mean, the extent of screening that would be done for cruise ships and those other vessels that come in, but are we reaching out then to all maritime traffic around the island?
The answer to that would be yes. Every vessel coming into Trinidad and Tobago has to be cleared by Immigration and Customs. And there's a examination of all the crew, all the passengers, the documents. I'll let Customs speak about their cargo and what persons are bringing. But in terms of the people, yes, they have to go through a screening and interview by immigration officers at every official port of entry. And there are 14 of them within Trinidad and Tobago.
So this last question will go to national security. So official ports of entry were just indicated. Are we in any way able to look at what's happening at the unofficial ports of entry?
Thank you and good morning again. Yes, that has also been raised. That matter has been raised at the Ministry of National Security with the Defense Force, particularly with the Coast Guard and the police who do the border patrols. They've intensified their patrols, and also they have actually put in place certain protocols in the event, in the unlikely event that there are persons coming through illegal ports of entry, and how those persons might be treated as well.
Okay, I just want to ask one question. Is the virus spread airborne at all?
So the main mechanism of spread is droplet infection, which is airborne, just like any viral, like the common cold or influenza. So it's similar mechanism of spread. There have been reports of spread through the mucous membranes, which I assume would be through contact mucous membranes of your eyes, which generally speaking is a sort of weak point in the skin. So you have mucous membranes of your mouth and your eyes, which things can actually permeate pretty quickly. So there has been documentation in one physician, I think, that he thinks that he would have had spread in that mechanism, not wearing his goggles. But generally speaking, the mode of spread is through coughing and sneezing and droplet infection.
Thank you. Member Ryan.
Thank you, Chair. No, I understand that the virus can be transferable through meat, raw meat. Do we currently have any perishable agricultural produce coming out of China or coming out of the US that initially originated from China? And what mechanisms are being put in place to investigate whether these agricultural produce are coming in and to prevent entry?
So generally speaking, I think there was a link between, some people have said snakes, some people have said bats, raw consumption, that kind of thing, handling in the markets in China, that would have led the zoonotic infection to come first to humans and then human to human thereafter. Ministry of Health wouldn't have that. I think the Ministry of Agriculture would be better placed through their CVO, the Chief Veterinary Officer, to know exactly what is coming from China, but anecdotally we would suspect that we don't expect that kind of produce that they have in their markets to be coming here as an import of Trinidad and Tobago. So it will be other types of produce.
Have the Ministry of Health engaged the Ministry of Agriculture?
We have a constant relationship with the CVO through our Food and Drug Division and our Veterinary Public Health Division. So they will send anything to us that they deem of interest, and they haven't indicated to us that they have a concern at this point out of China.
Okay, thanks. Now, I have another question, Madam Chair. Now, the word around, based on what I see circulating on social media, is that this thing is not as bad as Ebola and SARS. Are you in a position to verify that?
I said it, and I think people are speaking in terms of the death rate. So when you look at SARS, as I said before, would have been somewhere around 10% in terms of mortality, which 1 in 10 persons that would have contracted it would have died. Ebola is much higher than that, somewhere between 30 and 60% in terms of death rate, and that's why I think people are saying it's not as bad, based purely on the death rate. And that's the only part of it I think people can be looking at, because we had said 3%. Expectantly, after the outbreak is gone and they do retrospective studies, it will probably be less than 3% for this particular illness.
Member Bodo.
Madam Chair, again, through you, PS to CMO, what has been the extent of the private sector engagement in terms of surveillance?
So the private sector, we normally have sentinel surveillance conducted in all counties in the country. So generally speaking, we have about 8 or 9 physicians in every county, private sector physicians, that are part of our surveillance network. So if they pick up anything onto what they refer it back to the CMOH office, and they will in turn refer it to us. So that's a standing relationship.
Formal engagement?
I think it's a gentleman's agreement that would have started many years ago, but the surveillance agreement continues. I think there's an exchange of vaccines for information, that sort of thing. But beyond that, the Trinidad and Tobago Medical Association, wider, we have engaged them. We actually met with them yesterday, as a day before yesterday, to actually give them a presentation on the coronavirus, tell them the risks, so that they could share with their membership directly. They are having a symposium, I believe, on the 16th, which would include PAAC and Ministry of Health, to try to get their membership fully aware of what is going on. So that is already planned.
Member Olivier mentioned the issue of the ports that would not be part of the normal screening process. So my question would be, the health centers in these areas, for example, in Cedros and Granville and so on, Erin, Palo Seco, where some of these, you may have illegal immigrants coming through, would they be put on higher alert? Would the staff be more sensitized there?
So Cedros was pointed out to us early on in terms of a port that you would have persons from China coming in. And all the health centers around would have been alerted through the office of the CMOH for St. Patrick. So that has been done a few weeks ago. So they would be, of course, they would have been trained to know what signs and symptoms are, how they would do testing, how they would send the surveillance information back up.
So those health center staff
they
would
are
be
on alert, yeah.
higher alert, yeah.
Any county that, which is most counties that would have a port, would have received that sort of training a few weeks ago.
Sure. Going forward, CMO, do you have like a multi-sectoral committee that would meet on a regular basis? What's the way forward in terms of surveillance and planning and so on?
Right. I think we have met with the key stakeholders so far. Ministry has a steering team, which includes the Office of the PMO EH as sort of the focal point going forward. But all the regional health authorities internally, so there's an internal network. We created an internal network. There's a WhatsApp group that has been formed as well internally to share information rapidly on cases, on changing guidelines, those kinds of things. We have met with the stakeholders in the room, I think, as well. But I believe there's room to have some sort of committee set up so that we can actually have frequent dialogue related to it. But again, through the offices, through my office to the office of the Chief Immigration Officer and the Comptroller of Customs, we have direct communication on a daily basis sometimes as we progress. So that exists as well.
So there is no formal committee set up that meets on a regular basis as yet?
No.
Because I know with the Ebola threat,
With
that
Ebola,
step
there was a health committee that would have met very often under the auspices of national security, I believe,
Yeah.
to have those discussions at that level.
So your recommendation would be the same should happen for?
I would recommend that we do it at this point, so that, again, resources can be allocated if need be to the most part, and information sharing can occur at that level.
Sure.
So at a higher level.
Yeah, you know, CMO, we've had SARS, we've had MERS, we've had H1N1 Ebola. Can you say that, whether we have a national public health emergency preparedness and response plan that could address these respiratory diseases and other public health emergencies? Do we have something in place, or are we
So
developing
there's a
something?
plan emanating from 2014 that continues to be adapted, and of course is different for every disease. So every public health disease would pose some slight variances in the way you respond to it. But Ebola being the highest level threat in terms of a biological containment level 4, we stepped down from there. So once we had that plan since 2014, and we continuously adapt it for the other diseases as we go along.
Is that a document that you'd be in a position to share with this committee in writing?
Yes, we can share in writing.
Through you, Madam Chair, if I can request that.
So then, can I ask, so since this global threat, have we reviewed that preparedness plan?
WHO as well sends separate revisions, and what we really review is the actual intricacies of the diseases. So the parts of it that will change is basically the clinical lecturing and training that we will do will be different for each virus, so each disease. So we review those aspects of it, but the general scope of the plan remains more or less the same, but we will change it and adapt it based on each public health threat.
So just to ask, Doctor, you spoke about, training and so on. In terms of the WHO and CAFA would have sent out like interim clinical management protocols and so on. Do we follow those?
Yes, we do. Yeah.
And how do we disseminate
Right,
that
so there's
amongst our various?
So there's two mechanisms, 2 or 3 ways we do it. So basically we have a network of clinicians, both public and private. So the public sector can be broken in loosely into secondary care, tertiary care, which is hospital level care, and primary care. Primary care meaning the health centers and the like. So we have disseminated to the health centers via the county medical officers of health, which is one per county in Trinidad and one in Tobago, the guidelines, and they do their training. We also have a PowerPoint presentation that was adapted. So, and for secondary care, we use the directors of health and the chiefs of staff to disseminate to their staff in all the hospitals. So that's there. The Trinidad and Tobago Medical Association also assists us to get, as well as the Medical Board of Trinidad and Tobago, to get to the private sector persons and disseminate the information to them as well. So the key things they want to know at this point is the case definitions, how you report a case, how you test a case, and basically how you, is there any specific treatment at this point? That's what they want to know at this point. And we have been sharing that with all of them.
And are you satisfied that this is satisfactory, is just sufficient?
I think it's satisfactory at this point, given the type of virus that we're dealing with and the fact that there's no specific treatment. Most of it requires just supportive care at this point, similar to any common cold. So I think we're satisfied that the clinicians will pick up quickly if there's anything that we have to add, but we haven't said to them that, of course, there's no vaccine, there's no medical treatment, so they don't need training in that regard. So it will, these similar guidelines to influenza will hold, aside from the vaccines.
Right. Thank you. Member Dionorai?
To the Chief Medical Officer again, do we, in the case of an emergency, just in case of an emergency, do we have a guaranteed supplier of medical supplies? For example, the masks and all the other equipment that would need for quarantine and for protection or
Right.
transmission?
So we would have purchased, as part of our normal routine, N95 masks, which are the masks that are recognized during our tender, right? We would have received 25,600 at our central stores level. So we have that in stock. Generally speaking, there's a contingency in place through PAHO WHO. In the event that we require more than that, PAHO has a supply, I believe, out of Panama that we can pull on over 24 hours if we need additional supplies. Outside of that, the suppliers generally are pulling from a supply that the world is pulling from. So the only one we can guarantee beyond that is really the PAHO supply and the PAHO stock, which is an emergency stock that we can pull on as a member state.
And that PAHO stock,
Yeah.
it is guaranteed within 24 hours?
They have indicated to us that it can come to Trinidad in 24 hours.
Okay, thank you.
But that stock
Yeah.
is available to the entire region?
It is for the regions and for the region of the Americas, and we assume that they have capacity in there to deal with the region of the Americas.
Okay. So as we're talking about masks, we're seeing a lot of people walking around with ordinary surgical masks. Does that work? Does that help in any way?
I think any sort of protection you have from getting any particulate matter into your respiratory system will help to some regard. What is recommended is the N95 because it filters out 95% of the particulate matter. That's why they call it N95. So that's recommended, but it's recommended for frontline workers, for someone that will expect to be in contact with an exposed individual. And we don't recommend to the population at this time to be wearing any mask because we have no suspected or confirmed cases. So generally speaking, masks are not expected to be worn by anyone outside of people in the health system or frontline workers in immigration or customs or people handling cargo, whatever it may be. So they have varying levels of protection, but N95 is what is recommended for frontline.
And might I ask, what is a proper PPE kit in these circumstances?
So it depends on the level of risk. So for, let us say, someone working in immigration or customs, we would expect PPE to be basically gloves and masks because your exposure is expected to be very low. For a physician...
And Dr. Not to intervene, the mask you're talking about here
is the N95.
Thank
right?
you very much.
When you go to a hospital setting and you have a team that is set up to deal with an isolated case, you would expect that to increase to actually have gowns, you have face shields, sometimes there's a full gown that is considered a kit, a PPE kit. So it actually goes all over your shoes, it covers your entire, goes up to your wrist, you have gloves, so there's no skin exposed, you have goggles and you have a mask. So that's the higher end of it. When you deal with threats like Ebola, there's hazmat suits that have their own respirator and all sorts of other things. But generally speaking, it varies, depends on your risk, and we will be giving different people different levels of PPE based on their individual risk.
Okay, so Dr. Bodo?
Sure. CMO, the N95 masks, those have a lifespan, and they can last a certain number of days?
Well, generally speaking, it can be reused, right? It depends on the level of care, of course, that you give it. I would have had one years ago that I used for almost a month and so working in primary care.
Sure.
So it can be reused. Once it is in good condition, it doesn't get wet and lose that sort of barrier. It can be reused for quite a long time.
Yeah. There seems to be some level of panic in terms of acquiring those masks, because as a physician, I tried to get some as well. And apparently there seems to be a shortage. Can you?
Well, the unfortunate thing is that China produces most of the masks. So therein lies the issue.
So I just wanted to come back to, in the event, hopefully in the unlikely event that we are faced with a potential epidemic and disaster, the rapid response teams are part of the overall plan.
Yes, the rapid response at the different regional health authorities are part. Dr. Pratap would have conducted a tabletop drill week before, and we plan to do some actual physical drills. I don't know if you want him to go into any detail with the tabletop.
I haven't heard my colleague's voice for the moment.
Good morning. Through you, Madam Chair. So yeah, we did have an exercise last week Friday where we brought together the regional health authorities, and the regional health authorities, we asked for the heads of departments of the accident and emergency, both from the medical fraternity and the nursing fraternity. So that meant for us, it translated to the leaders of the response at that level. We had the disaster coordinators or a like office from the regional health authorities in the event that the matter escalates and you need to enact a larger scale response. So they were also there. But then we also partnered with the county medical officers of health. So every CMH was there from the primary care perspective, and then the Airports Authority and the Seaport, the Port Authority of Trinidad and Tobago, and the ODPM. So they all came together, and within this simulation, we had a scenario that spanned a person presenting on an aircraft. Mindful of the fact that when we look at the evidence from 2003, SARS, and the transmission on the aircraft, for one particular event, one particular aircraft, they sort of followed up these passengers for 90 days post to see whether any of them had developed any symptoms, as well as whether their blood chemistry showed any evidence of. So in all of those, there were no such cases. So hopefully that'll put into context the risk associated with air travel and being on an aircraft. So that was still tested, and then we tested a person presenting at a health facility, a primary care health facility, with fever and respiratory symptoms, not declaring a travel history. So it was sensitive enough to cue in the healthcare providers, the first responders, to seek exposure history. And again, as CMO was saying, it isn't restricted to travel, it's restricted to, it is broader an exposure, that direct close contact. And then we also had a person presenting within the ER in acute respiratory distress, meaning a severely ill person, whereupon you can't get a history of travel so that you have a relative there. So the scenarios are a really complex one, as real as possible as we could have gotten. And we tested three things. We tested the ability of that scenario to escalate to the ministry becoming aware of an event, and then so with ODPM being there, the need to escalate and keep the information circulating among all partners. And then we tested the ability of the first responders to be able to detect, to apply the case definition, the clinical criteria of what constitutes a case, a suspect case, a probable case, or a confirmed case. And we were happy with the responses that we got, that we saw from the RHAs being present, the health services providers being present. Likewise, with the Airports Authority, we were happy with the response that they had, and they were able to marry with that of the Ministry of Health and Port Health. So we are comfortable that the systems in place, in as variable conditions as we could have applied in that scenario were tested, and we were happy with the response that we had. As CMO indicated, we have the plans for actually doing physical exercises where we'll test different things. Just this morning, we had a conversation with the acting GM for Port Authority and sharing 3 things that we want first responders at, non-medical first responders, staff at the port, staff at the airport, and this is something we've always been sharing with the airport. 3 things to do. You contain, control, and communicate. So you don't put yourself at greater risk because, again, you do not know what it is. It could be novel coronavirus, it could be SARS, it could be MERS, it could be something else. So you contain the situation, you control persons from getting exposed, further exposed, and you communicate to your next in line so that the message goes up through the appropriate channel.
In terms of the spirit and the cooperation of staff, and I ask this because I know with the 2014 Ebola threat, there was some level of concern. What has been the level of cooperation and the spirit of the healthcare workers and the other staff who, the ports and so on?
Well, I think specifically to the Ebola, there was trepidation on the point of the staff because of the high mortality rate. So 30 to 50% based on exposure, there was a sort of staff pulling back and saying, I don't want to be on the front line, right? And there was talk about doing, in terms of human resource, actually doing plans, medical plans, life insurance plans, those kinds of things. I think because the threat is much lower in terms of mortality for this illness, we don't have that level of resistance. And especially persons seeing on a daily basis influenza and the like, the familiarity with that particular illness doesn't hold for the same as it would hold for Ebola. Notwithstanding, I think we had discussion on the HR part of it and making sure that, one, we have lists of persons that can be there in terms of contingency on call out and that sort of thing, properly trained, and then looking at their contracts to build in life insurance and whatever may be, and maybe even hazard insurance, so that those talks with the HR departments have begun.
Yeah. Is there an avenue for volunteers to participate or cooperate with the official agencies in the event of a large scale?
Yeah, voluntarism is something that we always happy to get the assistance of volunteers in any event, especially with a disaster. It increases our capacity greatly.
Sure. I just wanted to go back to the scenario of an acute case taking place at one of the emergency departments of one of the RHAs. So what exactly happens? Would that person be isolated in the RHA and then transferred to Cora?
Yeah. So
how is that going to work?
Yeah. So basically, as Dr. Paradapsing indicated, in this particular instance, the person wouldn't be able to give a history of sort. So we don't know what we're dealing with. We're dealing with acute respiratory illness, severe, and it could be many causes at that point. So we would expect that the staff integrating would wear the appropriate PPE. They would be isolated in the hospital A&E. Sampling should be done right away through CAFA. We await the response, and then if there's clinical suspicion based on whatever factors come, if the family gives some history later on that there may be a history of travel, then of course we send to Cora for further quarantine.
So that patient, if needs to be ventilated, will be ventilated in the A&E?
In the hospital.
Would not be admitted to the ICU of that hospital?
No, I don't think we will. I think because Cora being as it is, I think it has to be in the best interest of the patient as well to some extent. So you would definitely need, in that particular case that he described, you wouldn't have an idea from the history what is going on. But at the end of the day, we can't do any harm. As physicians, we ascribe to doing no harm first, as a first principle. Oh. So we have to take care of the patient, not knowing what they have, give them the best level of care that we can offer, and isolate as best as we can.
But you understand the possible scenario there,
yes.
because
yes.
if you admit that patient to ICU where you have
yeah.
others,
and
then you
again, we have to look at the possibility of having ICU suites that are separate and apart, and take the necessary precautions as need be. But again, we don't expect that sort of infectivity as we would expect for Ebola. So the distancing will be different.
Yeah, I'm just trying out that possibly. You understand where I'm coming from? I just wanted to confirm, you mentioned that next week that CAPA would be in a position to do the PCR testing.
Yeah.
And just to confirm, you said the results will be available within
The virologist at CAFA up to 2 days ago confirmed that it should be able to turn it around maximum 48 hours. The reagents are actually in the country already. What they're waiting on is isolates to run their testing, the controls, which is coming by PAHO diplomatic pouch, so I assume it should actually be here. I didn't talk to them this morning, but it should be here very soon. Once they can do that, they will have it up and running.
And
But
what kind
48 hours is the time frame.
Yeah, and what kind of capacity they would have in terms of number of samples and daily
Well,
basis?
seeing that we don't expect, they didn't give me a number in terms of capacity, but generally speaking, they have a fair amount of capacity because they deal with the Caribbean. In addition, they indicated that they're going to bring some rapid testing kits which have a high level of specificity, which will turn around in 2 hours. We won't be using the negatives. So in the event that we get a false negative for a rapid, we basically we will still send them to PCR for confirmation. But the rapid will give us a sense if you get a positive. Within 2 hours, you know what you're dealing with. So they will be bringing the rapids as well.
Thank you.
Member Newline?
Thank you, Chair. To the CMO again. Now, in the event that something happens, we all know here that this requires a coordinated response. Not only Ministry of Health, but we need all hands on deck. We need Port Authority, Airport Authority, Ministry of Health, Immigration, Customs, the regional health facilities, and also the Ministry of Finance. So is there like a manual in place or some sort of algorithm that you have in place outlining the procedures and the protocols that each institution needs to follow? And is this available to each one of the entities?
Yeah, so I think that goes back to the initial plan of 2014, where we would have had all the individual SOPs for different agencies. But for this particular illness, it's slightly different. But the interaction that we have had with all the agencies seem to be that we all on the same page in regards to the SOPs that would be used for different areas. So I believe we are in a good place where it relates to that.
And I just want to get some clarification with the travel ban and restrictions. If I were a Trinidadian national coming from China and I would have been outside of China more than 14 days, I have no symptoms. If I got to PAAC, am I still screened?
Anybody, I mean, prior to this event, anybody coming through PAAC would be screened anyway.
Anyway.
To determine, similarly to the ships, the captain of the ship is supposed to actually give us a declaration of health, which will say whether there's anybody ill on board. But you're saying basically you have no symptoms. Once you cross the incubation period, which is 14 days, so maybe you leave China, you go to the States for 2 weeks, and then you come to Trinidad, generally you should be no risk to the country. We will be allowed in as per usual.
All right. So, okay. So I want to ask, I don't know if it's Immigration, Airport Authority, and maybe Health. In terms of Carnival and the influx of visitors, how does screening operate? Would all flights be screened?
From a health perspective, all flights are being screened at present. We have the high-risk sports. High-risk flights originally were being screened, those from North America, Canada, Panama, as well as UK. But we expanded that only a couple of days ago to include all flights. So all flights are being screened by way of thermal scanning. But we always receive the declaration of health that is ongoing before any flight is allowed to disembark. The captain will say no persons are ill on board, and then we proceed from there. So all flights will continue to be screened.
Okay. And therefore, how does that impact, and I don't know if this is Airports Authority, how does that impact on the flow of passengers through the airport coming in for Carnival? I mean, because generally, if 2-3 flights land at the same time, big flights, we do have a backup. How does that work?
Generally speaking, around seasons such as Carnival, it's expected that we'll have high people traffic in any event. And we just try to manage it as best we could in terms of forecasting arrivals and ensuring that we have the appropriate level of staff placed in such a way that it can complement whatever is coming. But that is in the normal run of things without passengers being screened. If it is that over the course of this season that the passengers have to be screened as I gather that they must be, it is going to slow things down, but I think it's an acceptable inconvenience in the circumstance.
Okay, I understand that. Therefore, could anybody give, or is there going to be any mechanism to determine what is going to be the waiting time?
We can work that. We can work that by trying to model it. I think there's currently a rough estimate in terms of how long it takes to screen a particular individual. I got it from one of the websites, and I don't remember off the top of my head. But to answer your question, it is going to slow things down, Madam Chairman, for sure.
Oh, okay, so General Manager, I'm asking now from the perspective of if I, Trinidad resident, had to go and pick up a passenger at the airport, whether it's ENR, whether an idea of giving some sort of advisory as with respect to waiting time. So I don't get to the airport to pick up somebody at 5 o'clock who's coming on a 4:30 flight, and I have to wait till 9 p.m. So that and I think these simulations could be done.
Yeah, we can model that over a relatively short period of time and get that information on to you, Madam.
So if you do the modeling, could you maybe in the next 5 days present that to the committee?
Certainly.
Okay, thank you. Member Oliver.
Thank you very much. We're screening all high-risk flights through a thermal screening. How long does it take to pass through the thermal screening?
So basically, you come off onto the bridge. The officer actually stands there with a handheld thermal scanner. It doesn't impede it doesn't cause any delay in terms of passengers coming off the flight. They just walk past you and they do a group of people at a time. So you'll be able to pick up the odd person that has a high temperature on the scanner itself. So they just walk past. We don't ask anyone to stop or the like. So they go past our officers without any restriction in terms of time.
And
so I don't think it adds significantly to any normal practice that we have from the health side.
How many scanners?
Right. So we have 5 handheld thermal scanners at the airport, and we have 2 fixed ones, which are on the walls on either side of when you enter the main immigration hall. There are 2 sides. There's one on either side, which we can actually screen with as well.
So there really should be no delay
from our
as
side,
a result of
thermal scanning, no.
Okay, so that's something we don't have to worry about. Declaration of health. So the captain sends a declaration and saying there are no ill persons on board. I've been on flights. How do they say that conclusively?
I think that's up to the captain, but generally, because it's not only from the time of leaving, it's during the flight itself. If you have somebody ill, and it's a legal document, so it can be if they fill it out wrongfully, they can be imprisoned as well under the act. So the onus is really on the captain. Of course, we verify now based on checks, and that's why we have our port health officers stationed at the bridge to receive the document and also to verify that there's no one ill-looking before the thermal scanning, ill-looking coming off the plane.
Okay. Yes, this one will be for the Port Authority. In terms of your education of all the workers at the various ports of entry. So I know that, you would have educated all the immigration staff, all the baggage handlers, all the workers. Have you extended that education to the taxi drivers who would be taking the passengers to their destinations so that they are aware that they should use hand sanitizers and all these things? If not Port Authority, or Airport Authority, any agency that would have undertaken to conduct education of personnel who would be interacting with visiting passengers?
We have spread the information out among the rank and file of all airport users, including airport staff and so on. I doubt very much whether it has gotten down to the level of people like taxi drivers and so on. But that is something that we can check on and make sure that it happens in relatively short order.
When you say you've spread the information, could you please elaborate?
Yeah, all of the major or primary airport stakeholders, especially the airport authority workers themselves, both in security operations, general administration, and so on, airline handlers, baggage handlers, and so on. We have our own public education program that is consistent with the credible information that has been put out to the public so far. And we've been disseminating that information to all airport staff and all airport workers over the course of the last couple of weeks or so. And I think there have been 2 tabletop exercises that Airports Authority staff have attended as well.
Disseminate via email, WhatsApp, exactly? How do you test that the messages are being adequately received?
Emails and WhatsApp so far. Email and WhatsApp so far.
Okay, well, I would ask you to expand that, your knowledge net to include all persons who are stakeholders in the airport
Yes, ma'am.
population. I want to just kind of follow up on a question that Member Diona Ryan would have asked. So in terms of the protocols for handling it, as you're going through this experience, are you seeing any limitations in the way that we are treating with the overall mechanisms to address this public health emergency of international concern? Any limitations you're seeing, any recommendations that you think you can make going forward, so when we have similar types of incidences, we'd be better prepared to respond? Anyone can take it.
Yeah, the only limitation is I think we need to have some sort of multi-sectoral committee that can liaise on a frequent basis in a formal setting with a terms of reference that could actually bring this whole thing together.
So, Dr. Parasram, if I remember, you said that next week there's supposed to be some sort of interagency mechanism.
Well, no,
Is this what you're talking about?
No, we have interagency meetings all the time, but I think we need to have a formal committee established to deal with the matter at all levels. So we have our meetings and we have, but it's not a formal sort of meeting.
And who takes the lead in establishing this formal committee?
I know when we had Ebola, national security had taken the lead for that level threat, and I believe the same will hold.
Mr. Pierce, you wish to make an intervention here?
Well, I think national security certainly chaired the committee. The Ministry of Health took the lead, because the Ministry of Health, when we look at the integrated dangerous infectious disease response plan for Trinidad and Tobago, identified the Ministry of Health as lead agency. So, but I think on the last occasion, looking for somebody who would lead the committee, the Ministry of National Security took that.
So could I ask that between the 2 ministries, one decides who takes the lead, and that a report be sent to us by Wednesday with respect to the establishment of this multi-sectoral team? Okay?
Thank
so
you.
if we could have a response to that. Today is what, Wednesday? Oh, Wednesday is kind of long, Monday. I thought today was Friday. Okay, and Dr. Bodo.
Madam Chair. There was one more question which has escaped me now, but I will just close by thanking all the stakeholders and urge you to. I know I commended the medical team, but of course that goes across to all the stakeholders, all the agencies, and to thank you for coming this morning and for working together, and to urge you to continue. It's not easy. I'm sure it's a challenge because CMO, as you know, we really don't know for sure how this is going to evolve. But it's reassuring to see that we're somewhere along in terms of preparedness.
Okay, and before we close, I have 2 questions, and it's really to help with public information, I hope. So I know CAFA would have issued these advisories and bulletins and so on. So I want to ask, what can I do to protect myself and my loved ones? And therefore, if somebody could sort of itemize for the benefits of the general public, because we talk about proper hygiene and so on, but I'm not sure that tells us step by step what are the things we should do as proper hygiene.
So basically, in terms of your threat, first of all, we have advised against going to China at this point. So that's first and foremost. In terms of being in Trinidad, your threat is more than likely to be influenza than to be coronavirus. So you're looking at frequent hand washing, covering your nose and mouth. If you sneeze or cough, if you're ill, you stay at home. If you're working or if your child is ill, keep them away from school until the symptoms abate. You use hand sanitizers if you don't have running water at the time, as frequently as possible. You cough into your sleeve if need be. Generally speaking, in terms of food hygiene coming around Carnival, you want to be very careful what you eat. If you're buying food outdoors, make sure your vendor has a food badge, a valid food badge. Again, washing your hands frequently, making sure you prepare your food well, and your sources are good sources as well. So general measures to protect yourself for the season, influenza season and the Carnival.
Okay. And one last question. If I had recently traveled to the United States where there are cases, and I came home and I wasn't well, what sort of steps I should take?
I think the key thing is to inform your healthcare provider as early as possible. So, and let them make the decision as to what they think it is, give them the full history as to your level of exposure, and then it will be determined based on testing and otherwise.
Okay. Well, I just tripped, and it was designed precisely to do that, to trip Member Boodoo's memory. Member Boodoo.
Thank you. No, just one more question, Sid. Would you play mass?
Personally or during the season?
No, as advice.
I mean, I don't think there's a risk of coronavirus to the country, given all we have discussed. When we speak of influenza, it is Carnival and close mingling of people is considered a threat to public health, spread of disease generally. The two main things you get is common cold, influenza, and gastroenteritis during any Carnival season or any season where you have big gatherings coming together. So the precautions are necessary, but I mean, everybody has to assess your individual risk. And of course, the people belonging to the high-risk groups are more prone, those over 65, children under 5, pregnant women, those with immunocompromised states, have to pay particular interest, diabetics, asthmatics, and the like. So you have to gauge your personal risk. You can ask your medical practitioner what they think in those circumstances as well. All right?
Thank you very much. And therefore, I would wish to bring this public hearing to a close. I want to thank all the representatives, Ministry of Health, Ministry of National Security, the CMOH, the Principal Medical Officer of Environmental Health, CMOH St. George West, Immigration, Port Authority. I just wish to thank you all for coming and assisting us in this very informative session. I didn't mention the Ministry of Finance, okay, in my wrapping up, but I want to thank you all. And I would just hope, as undertaken by the PS, admitted and undertaken by the PS and the Ministry of Health, that the public sensitization be ramped up with respect to how do we protect ourselves and proper protocols that we should follow. I wish us all best success in maintaining our status of low risk and no cases. Okay, so that I thank you all, and you all are excused. I thank the members of the media who stayed with us. I thank the members of the listening public who've stayed, who sent questions. Thank you. Pleasant afternoon.